This painting done by Sir Luke Fields in 1887, it's named The Doctor. But it's really showing very beautifully the patient-physician interaction. This is a Victorian-era general practitioner having a home visit to a child patient. And you see the light on the face of the physician and the patient. The physician is totally centered on the patient. The parents in the background, they're not that important. And the physician is really present in the moment there for the patient. For better or worse, we don't do home visits anymore. And if we forward to 2012, many years later, this is what we get at the best. This is, tomorrow we'll have actual patients giving their perspectives. So what I'm doing now in the next 30 minutes is talking from the context of a physician who is seeing patients with functional bowel disorders, predominantly patients like that over the last 10 years, and also have done some research in that area on patient perspective, patient education, and patient-physician relationship. This painting done by Sir Luke Fields in 1887, it's named The Doctor. But it's really showing very beautifully the patient-physician interaction. This is a Victorian-era general practitioner having a home visit to a child patient. And you see the light on the face of the physician and the patient. The physician is totally centered on the patient. The parents in the background, they're not that important. And the physician is really present in the moment there for the patient. For better or worse, we don't do home visits anymore. And if we forward to 2012, many years later, this is what we get at the best. This is 14 minutes per interview in the United States, per visit. The average time physician spends with a patient is 14 minutes. And the average time of interruption of patient when they start talking in the beginning of the interview, it's 14 seconds. So we may get a smile, a hurried smile from the physician, but the interaction is pretty brief. And most of the time, unfortunately, it's becoming more a computer interaction, and some people now call this an eye patient. That's how rounds are done in medical schools, around the computers, around the EMR, electronic medical records, and very brief interaction with the patient. And even worse, the physical examination sometimes is reduced to copy and paste from the EMR. There are many different challenges to the patient-physician bond. There's so many factors within the healthcare and outside of healthcare that modulate the behavior of both physicians and patients. Chronic illness, aging population, the influence of the internet, changing social norms. The public perception of the medical profession is totally different now than 100 years ago. The litigation increase in this country is having an enormous influence on this patient-physician relationship. Government regulations, new technology that's allowing less and less face time, increase of healthcare costs, decrease of reimbursement. All these factors are modulating our relationship with patients much more than we can even realize. What I would like to do is talk about who is the IBS patient, what is the illness experience, and briefly touch on some of the gaps I see in IBS care. We already know that a typical patient with IBS will have abdominal pain. There is no IBS without pain. So the patient will have abdominal pain and change their bowel habits. We went over that previously. Often, people with IBS will not seek medical care. Only 25% of those that have IBS will come to us. So there'll be many people in the community who can benefit from having help with their IBS symptoms, but they will not be talking about it. It's a taboo conversation. Bowel function, it's not a cocktail conversation, so a lot of people suffer without seeing us. Your patient usually will be a female in the ages between 20 and 40, just from epidemiological data. And your patient will likely have overlap with other functional GI conditions, not just IBS, but also dyspepsia, maybe some pelvic floor issues, and those conditions can kind of change from one visit to another. One visit can be predominantly dyspepsia, another visit predominantly IBS. The pain can also move from one side to another. Patients with severe disease will also have psychiatric comorbidities, which makes it difficult to manage because they'll have depression, anxiety, somatization as the top three. I've been thinking about why is IBS or functional bowel disorder different from other chronic conditions? What is the difference? I'm comparing here diabetes and IBS. The incidence of IBS is actually greater than that of diabetes, the spot incidence. About 10–15% of US population will have IBS. The pathology is poorly defined still, and IBS is better, and diabetes is better defined. The treatment, there's no single effective treatment of, as we heard, many different subtypes of IBS, and we have things to measure in diabetes. We have glycemic control we can base our management on. Morbidity and mortality, it's high in diabetes, low in IBS. Health-related quality of life, we saw earlier a few studies showing that it's actually the health-related quality of life in IBS is as bad as in diabetes and chronic renal insufficiency and depression. The cost, the healthcare burden is probably great in diabetes, but this is where the differences occur. Patient cognition and physician attitudes are very, very different between those conditions. Physician attitudes for IBS as a whole are negative attributes related to, is this condition even legitimate? Is it real? Or is it psychiatric diagnosis? Dr. Brian Lacey did a study a few years ago showing that 50% of primary care physicians believe IBS is a psychiatric diagnosis. This was in 2005, I believe. And it's not the same for diabetes. We all have respect to this condition. And the public awareness for IBS, there's a study from 2004 showing that when you interview the general population about how much they know about diabetes, IBS, heart disease, much lower proportion of the general population were aware of what IBS really is. Dr. Che and Dr. Drossman were with me when we lobbied in Washington a few years ago. And when we walked to the representative offices and tried to talk to IBS, almost all of them said, IBD? No, we had to redirect IBS. So the awareness of IBD even is so much greater than IBS. So this is what we're dealing with. We're dealing with a condition that's not well recognized. There's no pathophysiological markers. Physicians don't believe in it. Public doesn't know about it. It's embarrassing for patients. And this is one of the gaps that I see over and over again. And I think it's like the elephant in the room. I think one of our colleagues here mentioned this, that when he went to practice, he saw so many patients with functional bowel disorders, but didn't know how to deal with them. We can run, but we can't hide. 25% of primary care patients will have IBS. And in GI offices, 25% in the GI offices will be IBS, and maybe even more if we group all functional bowel disorders. In primary care setting, about 12% of patients will have IBS. They may not talk about it, the discussion may not even get there, but they'll have IBS by criteria. So the disease impact is huge as far as prevalence, high cost, personal and societal, and impaired quality of life. But the disease status in the society and medical profession is extremely low. There's huge, huge disconnect. I would argue that even somebody like me who's been seeing patients with functional bowel disorders for 10 years, and I feel I'm quite sensitive to their concerns, this study that was done by Dr. Drossman in collaboration with the International Foundation of Functional GI Disorders really, really strike me. Because honestly, I did not appreciate what a patient's willing to give up for improvement. What would you give up to be free of IBS symptoms was the question. 2,000 IBS patients. They were pretty severe. they reported 73 days out of the year having poor health-related quality of life. So moderate to extremely severe IBS. 1/4 of them, they were willing to give 1/4 of their remaining years of life to have life free of IBS. And about 15% were willing to accept 1 to 1,000 chance of death or serious and disabling side effects if offered a medication that would give them total relief from their IBS symptoms. So I think even doctors don't realize the impact of this condition on quality of life. So what is the best way for a physician or care provider to figure out the perspectives of patients on IBS? I would argue that storytelling is how we figure out medical diagnosis. Medical history is a story. We often don't allow the patients to tell us a story, but the oral tradition is legends, and how we really figure out somebody else's perspective is by storytelling, interviewing, writing. So I chose to ask patients to do expressive writing about their illnesses, and that's how I elicit their perspectives. So we asked the patients to write very open-ended question write anything and everything about their IBS experience. And this was borrowed by the work of Penny Baker, a psychologist in Texas who did a lot of expressive writing studies in other chronic illnesses, showing that HIV, depression, hypertension can be improved by expressive writing. So this is just a small sample of patients, the first study we did. And we looked at the top 10 themes that were identified in the expressive writings. So this is IBS patients writing about anything about the disease. And what came up as top themes were frustration, foods as triggers. Everybody wants to know about food. Social isolation, medications that helping or not helping, interference with intimacy, which relates to isolation, embarrassment, worry if no bathrooms nearby, unpredictability of symptoms, hope to learn and get help, prevalence of abdominal pain, it's on the bottom. And what do physicians focus on? Pain. What's your pain out of 10? Patients don't want to know about that. Their theme is frustration, isolation, embarrassment. They can care less about the degree of pain. So about 10 years ago, Bertram did an interview, in-depth interviews with patients, and came up with the same themes that I came up with 10 years later. Number one was frustration, inability to control symptoms, to prevent episodes, to identify triggers and obtain validation of the condition. Isolation, anticipation of episodes, need to be close to the facility, embarrassment. The next thing was search for niche in the healthcare kind of system, trying to get through a physician who would listen, who can help. And that's associated with hopping, physician hopping and shopping from one to another, further increasing costs. Dissatisfaction with the care and the interaction in the medical community in general. And patients said repeatedly that the interaction with the medical community seldom clarified understanding of the condition or improved the management. So great dissatisfaction with care overall. And again, those are patients willing to go to clinical trials, moderate to severe IBS. So I would like to give you some real examples of writing regarding those themes. Because again, I believe stories is really bringing the point. And the way I got convinced that writing is powerful is when I tried to teach my GI fellows at Boston Medical Center. For about 4 years, we had conferences every month based on the model of Dr. Drossman about functional bowel disorders. And all these fellows were pretty cynical about IBS patients and really not very interested in learning communication skills until I gave them to read some of the writings and asked them to rate it and grade it. And every single endoscopy inspiring to be fellow came to me and said, wow, I never knew it's that bad. And I was thinking, for 4 years, I've been trying to tell you how bad it is and how we need to talk to patients, but the writing is what got them. Those are writings from young people who can they associate with, who they saw the real story, and they finally heard the impact of quality of life. So, IBS is frustration. Physicians are uncomfortable with it, not sure what it is, and most do not accept it as a legitimate diagnosis. Also, physicians are trained to fix things. There's no fix, so therefore, no success. And many physicians equate that with failure, so tend to avoid it altogether. Worse, some act as though it's all in your head and treat it as hypochondriac symptoms. IBS is frustration. It dominates my life. You must always plan for what if. What if I eat more? What if toilet facilities are not available? What if I cannot break away? IBS is frustrating. It's in its unpredictability, and that is the bottom line. I hate IBS. It makes me feel embarrassed every single day, and I feel like I'm losing control. I haven't told many people about my problem, just a few family members and friends. No one else knows. I wish this would just go away. Sometimes I wish I could be more open about it. I don't want anyone to know. I don't want to feel like the odd one with strange bowel issues. Isolation. I'm scared to take a job. I'm afraid that I'll have stomach problems while on the job and be stuck in the bathroom for a few hours. I'm also afraid that I'll be late in the morning because of unexpected problems. It's definitely not something that you want to go around telling people you have. Worst of all, though, is the feeling of isolation this condition carries with it. The physical isolation is a piece of cake compared to the mental aspect. There's simply no way anyone can know how it feels to be this physically and emotionally depleted without undergoing it themselves. Even the most compassionate of my friends and family seem unable to grasp how utterly devastating this condition is. Search for medical care, dissatisfaction with medical care, unmet expectations. The biggest problem is that no one in the medical field treats the whole person. I feel more like I'm going to a drug dealer than someone that looks at the problem in its totality. As a result, I have turned my attention to helping myself and have had some degree of success. Perhaps this patient has read the work of Plato, just like Dr. Drossman, who cited earlier that the greatest mistake in the treatment of diseases is that there are physicians for the body and physicians for the soul, although the two cannot be separated. So nothing new under the sun. Now, expectations are extremely important. They're linked with how patients do medically. So unless we identify what they expect from us, we cannot meet expectations. Dr. Drossman talked about that earlier. In this study, we asked about 1,000 patients around the country, what do they expect from their doctor who treats IBS, and what have they experienced in their last visit about their condition. And you can see the disconnect in pretty much every item. To provide comprehensive information, 96% of patients expected that to happen in their visit. Only about 38 said that they had that. Tell me where to obtain info on IBS. 95% felt that they should have that during the visit. About 89% were actually reported that they had some information, which is pretty high. Most of them are from UNC, by the way. Now, many physicians are worried about how much time demands patients have on them. They feel like patients want physicians to be spending a lot of time answering phone calls, and they feel extremely overwhelmed by that. But it's really on the bottom of patients' list. They want us to have a different relationship, not more, just different. Look, to return phone calls, to provide hope, to provide support was much more important to provide support, hope, to listen than to be available time-wise. To return phone calls within 24 to 48 hours, which sometimes is unrealistic. 80% expected that, about 52% experienced it, which again is pretty high. I was very interested in asking what is the most important thing a physician can do to improve his and her relationship with you, given that we only have about 15 minutes per visit. So I wanted to get to the bottom of what is that one thing we can do in a short period of time. And turns out it's to listen understand, believe me, hope, and be available. But look at the bottom, spend more time with me. Very low on the list, okay? The top priorities, listen, understand, believe me. So listening and empathy, I think, is the two key aspects of what patients want as far as the most important thing in the interaction. In all this research, the most fascinating part for me was to realize what a central role we as clinicians play in patients' disease experience. In the expressive writing studies, we did not ask them to write about physicians or their relationships. 70% of patients writing about their IBS wrote about the doctor. So the doctor is a central figure in that experience. And unfortunately, we didn't do too well when we peeped and looked at the writings. What did they say about us, patients? Turns out that in about 30% of cases, they were not happy with us, or even more. I need more empathy and listening from my healthcare provider. That's 27%. I lack faith in my healthcare provider ability to help me, 25%. Only about 17% said that my healthcare provider is helpful and reassuring. 8% mentioned that the doctors think they're crazy. 5% do not trust my healthcare provider. And then 18 more other themes, including talking to my doctor makes me feel uncomfortable. My doctor just gives me meds. My doctor wants me to go away. I wish my doctor would educate me about IBS, and so forth. Some of the things patients said: believe my symptoms, listen, understand, take me seriously, not tell me to live with it, verbally express hope, very important in a setting of chronic illness and long-term suffering, hope that things can get better. In fact, the UNC Center for Functional GI Disorders, in their logo, if you notice, have the word hope. And I thought that's very, that's really based on clinical experience with dealing with these patients. Hope is very important. Understand how much IBS affects my life and not give up, which is related to hope and collaboration. So we talked about the gap of IBS having a low status as a disease, but I think even more striking is the gap between patient's language and physician's language and agendas. This was mentioned earlier. Patients are interested in being listened to and feeling well, getting better. That's what they care about. Physicians are trained to diagnose, treat, and cure the disease. And the irony of it is that we all want the same thing. We want the best care possible, but we talk different languages. So what we're doing today and tomorrow is trying to learn each other's language and talk better. Even if we spend time to educate patients about IBS, they seem to be very reluctant to accept the functional diagnosis. Okay, a study from 2009 shows that 1 in 13 of patients accepted the functional diagnosis. Only 1 out of 13 patients that were told they have IBS accepted this diagnosis, despite being diagnosed by the doctor. Now, in 40% of the time, the MD underestimated the severity of patient symptoms. We already talked about it. I consider myself seasoned clinician as far as functional bowel disorders goes, and I do underestimate the severity quite often, I think. Patients and MDs had quite discordant views on what treatment will be best for their symptoms. So after the initial visit, there were so many misunderstandings, and the bottom line is patients left and they didn't believe they have IBS. You can imagine what kind of problems that will create later with compliance, with anxiety about cancer, is anything missed, all of these issues. In addition, patients hold a lot of misconceptions about IBS, which leads to more anxiety, more visits, and more misunderstanding. This is a survey, national survey of 1,200 IBS patients around the country, and you can see that about 21% felt that IBS will develop into cancer. 43% said agree to IBS will become colitis. 34% felt that IBS will need surgery later, and 29% felt that IBS will definitely become something else. None of this is true. It's all misconceptions. If we don't identify those misconceptions during the visit, we're not able to introduce new ideas. In fact, sometimes if I'm pressed for time, I would have a statement, by the way, I want you to know, in case you're worried, IBS never develops into cancer, does not lead to other conditions, does not need surgery. Yes, it affects your life, but does not become anything else. And the proper way to do it is to identify what concerns they have and then address them. But if the time is a real issue, I think it's important to discuss cancer and other presumed concerns. And close to 50% of patients felt that IBS will worsen with age, which is actually the opposite. For women, after menopause, IBS gets better. It's not the same for men, sorry. And doesn't shorten anybody's life, as far as we know. So, to sum up, what is the IBS patients? And this is moderate to severe IBS. Those are not patients or people with IBS walking in the community. Those are people who come to see us. They're frustrated, they're isolated, they're embarrassed, they feel dismissed by healthcare providers, which is very damaging to the relationship and damaging to their health outcomes. They're dissatisfied with their care overall. They do not understand IBS, and they're worried about cancer. What about the doctors taking care of IBS? Well, they're frustrated. They're frustrated with lack of definite treatments, with complex pathophysiology, with patients' cognitions, maladaptive coping, the fact that they're not getting anywhere, okay? They feel dismissed. I can tell you that colleagues who deal with IBS patients who believe in patient-physician interaction feel very alone often. They are not valued by the administration because money is not generated by seeing patients and talking to them. It's generated by doing procedures. And other colleagues who don't deal with IBS can look down and express verbally and non-verbally dismissive attitudes towards them. Oh, I have some IBS patients to send you, right? You experienced that before? So they're also feeling very lonely and dismissed. They're dissatisfied with their job. And what we'll learn here is that if your communication improves and you're able to deal with challenging patients, those are the patients who you start liking, and your job satisfaction increases. Learning communication skills results in improved job satisfaction, which is a wonderful benefit. They don't understand IBS very well. We don't understand IBS very well, just like the patients do. And we also worry, just like the patients. We worry about organic disease or missing things. What is needed? I think patient education is needed. Physician education is desperately needed, starting from medical school and further up. Somebody was mentioning about the empathy or the compassion disappears after the second year of medical training, around year 3. Somehow, all this compassion, people going into medicine lose their compassion. They have a lot of bad role models, by the way. So this will take generations to change, but I think symposiums like this and disseminating this ideas is very important. Changing the reimbursement structure so it rewards and incentivizes the relationship aspects of care and getting people better rather than doing things. In China, the physicians were awarded or rewarded only, in the olden days, only if the patient got better. So one of the signals the physician could get to the family that the patient is terminal is setting the price of their care very high. This was a signal to the family that I cannot help you, I cannot get this patient better. And think of what we're reimbursed. We're not even reimbursed for making diagnosis or making somebody better, we're just reimbursed for testing. I think the only way to do that, change the structure, change the reimbursement structure, is through a joint physician-patient advocacy. I think next time we should have a lecture about the doctor after the patient, because we do need to talk about our own frustrations. This is what doctors say about barriers to empathic communication. There's not enough time. This is number one, always. And we'll argue tomorrow in our communication workshops that time is much less important than what you do with the time. And patients' perception of time is based on how patient-centered the interview was. How many concerns were elicited, how many concerns addressed. If that happens, patients feel like you have spent a lot of time with them. And there's an excellent study showing that if you let patients talk, even the most severe patients will not talk longer than 2 minutes. 80% will stop after 2 minutes. But we feel like we need to interrupt within the 14 seconds. It's not relevant to dealing with acute medical problems. I disagree. Very relevant, and also relevant to chronic illness even more. It's emotionally exhausting. Well, Dr. Drossman just mentioned that empathy is not sympathy. We don't take somebody's pain on. We come around, we experience what they're experiencing, we come back right to us. It's not sympathy. We don't take their suffering. We associate with them. We see things through their eyes, and we come back. We're basically in their shoes for a moment, and we come back. It doesn't have to be exhausting. I don't want to open the Pandora's box. This is about psychosocial issues. Research is showing you don't even have to address psychosocial issues. You have to acknowledge them. That's the shortcut for short time. If you just acknowledge there's an issue and not necessarily going to address it, you have gained you have improved your interaction and your relationship with the patient. I haven't had enough training in empathic communication. That's absolutely true, and that is changing. I think training has to start very early in medical school and continue. That's true. We have not been trained properly in communication. If I use all my empathy, that's my favorite, at work, I won't have anything left for my family. I'd like to stop here and thank you very much for your attention. And I look forward to our workshops tomorrow.